Hello, Bilal. Thank you so much for joining us for this episode of Sir Podcast.
Thanks so much, Radha, for having me.
So, Bilal, you recently conducted a study on the role of trust in increasing resilience during times of crisis, specifically studying the healthcare response in Sierra Leone during the Ebola outbreak. Can you elaborate on the findings of this research and what insights this can provide in understanding the way the pandemic has played out in different parts of the world so far?
Sure, I'd be happy to. So, our research in Sierra Leone, which is in collaboration with a few other authors, Andrella Dubé at Chicago, Johannes Haushofer at Stockholm, and Darren Christensen at UCLA, and Martin Brewers at the University of Wageningen. Or all of us, basically started working in Sierra Leone in 2011, when Sierra Leone was starting a big push to provide free healthcare to women and children across the country. And we were not interested or did not know about epidemics, and the study that we started had nothing to do with responding to Ebola. In fact, Ebola was not even an issue at that time. We were interested in seeing how to improve healthcare systems and healthcare delivery more generally. And the study that we did was a randomized control trial of two accountability interventions or social accountability interventions that was really intended to create a direct link between the communities that were served by clinics and the clinics themselves and the nurses and staff who staffed that clinics. So it was about an accountability system to ensure that once this free healthcare was being provided, these communities would be able to directly benefit from it, and to hold their providers accountable if they were not delivering the services. However, when we, as a part of the intervention, the accountability really involved building these relationships between the communities and the clinics. So one of the treatments that we tried was community monitoring, based around work that had been done by Jakob Svensson and Martina Björkman in Sweden. And they had tried this in Uganda, just these community monitoring community monitoring kind of meetings where the nurses and the community would both be informed about the health status of the community, and then would be helping, ultimately would hold each other accountable for better health behavior, better standards of service, but also work together to achieve these improvements in health. What we found is that as a result of these, simply by making communities and nurses interact more and decide together how to improve their health problems, these huge impacts in particularly under 5 mortality, in all of these, I think under 5 mortality went down by about 36%. Children were stronger and healthier. People were using the clinics more, et cetera, et cetera. And these findings are very similar to what Martina and Jakob found in Uganda. And so this was a really exciting study for us. Shortly after our study finished, suddenly all of the West African region, and specifically the areas where Liberia, Sierra Leone, and Guinea are situated, so the tip of West Africa, was hit by Ebola. And this was in 2014 and lasted till 2015. It was the first time a massive epidemic of that size has hit a region. Ebola is a very scary disease. There was a lot of trust issues that were surfacing at that time in the country, because Ebola, some people thought it was a curse from God. Some people thought it was a Western ploy or intervention. Some people thought it had to do with the devil or with their local kind of religious beliefs. And people certainly did not think of it, many people didn't think of it as essentially a disease that potentially had a medical solution. What we found, and we got very sort of interested in this precisely because we thought, okay, there are now these clinics as part of our randomized trial who have been provided all of this, this kind of social, let's say, trust, or these interactions that communities and clinics have had, could potentially have changed the way that they view each other, and specifically might have changed the way that communities turn to their clinics when at a time of crisis. And we had these, so we had these treatment clinics which had been given these interventions, and these control clinics for comparison's sake. And so we said, okay, let's go back and look at the data. And we collected a lot of data from various sources that had shown, firstly, Ebola case reporting, where all the cases were, and secondly, Ebola related deaths. So of the cases that were reported, how many people died? So we went back, we looked at the data, and we found this very strange thing, which is that the number of cases reported in the treatment areas was much higher. And of course, you can interpret this as the treatment itself, the trust treatment having increased Ebola, but we really dug into the data and we saw, okay, clearly this is not the reason why, and the details are all in the paper, but it has to do with how Ebola itself spreads, the epidemiological kind of characteristics of the disease, etc. So if it's not that, then there's only one solution, or one possible reason, which is that actually the treatment encouraged people in the treatment areas to report Ebola. And this may sound familiar to you because, for example, I don't know if you were following in the United States, one of the first things and things that Donald Trump has said throughout his presidency was that, you know, in the United States, we do too much testing. And because we do too much testing, it looks like our numbers are much higher, but there are all of these countries that don't test, or they fake their tests, and so it looks like their numbers are lower. And it is true that many countries do fake their tests, but this was kind of the same pattern here, is that in the places where, in the clinics where there was or there was less trust in the control areas, people were just not reporting. They just never turned up to the clinics. They thought, we don't know these nurses. We have never worked with them. We rarely interact with them. They give us Western medicine, and maybe that contains all kinds of things. Our soothsayers and our traditional healers have told us to avoid those. Our family tells us to go to the local shaman, whatever it is. We don't go to the clinics. And so when they first started feeling feverish, which by the way is the same first symptom that happens in COVID as well, they would say, okay, I'm feverish, I'm going to stay home, or I'm going to go to a local, healer or whatever, and just they'll give me something or the other to deal with it, and I'll move on. Whereas in the treatment areas, we found this big increase in reporting. And now the key thing over here is that reporting is the first step to isolating, containing, and responding to an epidemic. It's only once somebody turns up, or once somebody tests positive somewhere, that you say, okay, let's isolate this person. They have to go into quarantine, into isolation for 10 to 14 days, as they do in COVID. We need to do contact tracing. We need to figure out every single person this individual has been in touch with over the last period during which they were infectious. And we need to give them whatever treatments are available, whether it's palliative care or it's curative. We need to address this. And by virtue of doing that, because this trust had created this 60% increase in reporting in the treatment areas, we also found this huge decline, between 25 to 35% decline in Ebola-related mortality in these areas as well. And so the big picture that we came away with is that local trust between communities and their health providers really matters in terms of detecting an epidemic early, because people are more willing to go and report to those clinics. And in all likelihood, it also helps those clinics directly respond, get patients to agree to do things that will prevent the spread of the virus, that will get them earlier. Patients will be more likely to take the medicine that they're given, and so on and so forth. And one more point I'll make before we go on is we also started doing the math in terms of how much these interventions cost versus how much it costs to respond once an epidemic is hit. And we found, because as you remember, we started before this intervention was done before Ebola happened. So the country was running as normal. And the amount of money that it took per clinic was about $2,400, as I recall, which is a certain amount of money. In comparison, we looked at Ebola treatment centers and community care centers that were established after the epidemic had hit, and they cost in the tens, if not hundreds of thousands of dollars, precisely because those centers have to be put in. All of the treatments, they come at a much higher cost because the entire country is shut down, the communities are locked in place, et cetera, et cetera. And we're finding this kind of everywhere as well. It is much harder to treat reactively any epidemic than it is to put into place the mechanisms that there are to contain it. And so those findings, I think, are also pretty convincing and kind of convincingly translate to what we're seeing in the case of COVID-19 as well.
Right. So given these research findings, what do you think about the role of trust in the upcoming stages of the pandemic, specifically as we move towards the challenges related to mass immunization? Do you think trust in healthcare would perhaps become a much more significant factor now?
Yes. So you see these patterns, right? So countries that have had past exposure, so Liberia, Sierra Leone, and Guinea, Senegal, Uganda, Rwanda, these countries, all of which have been at various points affected by Ebola and various other epidemics, but all these 6 countries were affected either directly or indirectly by Ebola. They've mobilized very, very quickly. They did the contact tracing, their populations were ready to receive instructions because they'd just seen something in the past. The experience of the epidemic itself built a trust in government because they said, ultimately, in these particular cases, because they saw that ultimately the cost of not listening and trusting the government was mass death, right? And they were kind of mobilized and ready. And then there are other countries like New Zealand, where there's huge trust in government. There's countries like South Korea, China, and Singapore, which have very strong command and control systems, so they know where all the citizens are. They have high surveillance technology. But if you look at the trust issue, the trust statistics, large proportions of these countries, I was reading an article in Nature Medicine that did a survey about COVID-19 willingness to take vaccines in 20 countries, I think, and they found that citizens in South Korea, China, and Singapore were much more likely to say that they would take the vaccine, and they displayed much more high trust in their governments, which is interesting in of itself. And as we've seen, they've also managed to really keep Ebola, COVID-19 in check as well. So that's one experience, which is clear that there's these kinds of patterns across the world that are applying already to COVID-19. In contrast, everyone's seen the complete embarrassment and horror of the United States, where one entire half of the country, because of the political environment and their political affiliation, just don't trust the government. And that is the half of the country that doesn't wear the masks. It's the half of the country that believes that COVID-19 is a infection generated by Bill Gates to plant microchips in people's system and harvest their DNA. It's that kind of crazy talk that then finds a lot more space when the trust in government isn't there. And it's interesting, I was thinking about this in the context of Pakistan. Nobody's done the study, but it would be very interesting, and maybe somebody will be able to do this when the data is, if and when the data is made available, about whether political allegiance has played a role in terms of whether people have, adhered to SOPs around COVID, whether because, let's say, they're PTI supporters, maybe they believe more that, they're more likely to believe what the government is saying about COVID-19 than maybe if they're not, and so on. I have no idea if this is the case. This is purely saying I'd love to know if there are similar kinds of trust-related um, uh, considerations that have driven how the COVID-19 epidemic has played out thus far in Pakistan. But going forward, hopefully there's a vaccine that's on its way. Certainly there are vaccines that are already being administered elsewhere in the country. In the world. There have been trials in the country that tens of thousands of people have actually signed up for and participated in. So that we do seem to be moving to a new equilibrium. But really the question here is going to be, I think, precisely the same. What do people in Pakistan, what do people in the world think um, about what the vaccine is? I was reading recently a news article, I believe, it was published in Reuters and reprinted in Dawn and others, where a doctor was talking about the kinds of questions he receives from his patients when it comes to the COVID-19 vaccine. Is it going to take away my ability to reproduce? Is it going to kill me? Is there a 5G chip in this? There's a big conspiracy around 5G technology in cell towers. Is this a way of surveilling people en masse, etc.? And as you, of course, remember from 10 years ago, when the United States decided to use Pakistani doctor to identify and track bin Laden, which led to a massive decline in the increase in the trust that people had in healthcare workers in the Northwest, and particularly polio vaccinators were targeted, polio vaccines were rejected, and and Pakistan is one of two countries now in the world where polio made a big comeback, the other being Nigeria, again, a country with huge trust issues in government. It's very clear that going forward, these kinds of conspiracy theories and these kinds of breakdowns in trust are severely going to hamper, on top of all of the other problems that we have about distributing a vaccine to billions of people across the world, and not just one but often two doses of that vaccine in a timely way with massive refrigeration, etc. The biggest and saddest issues will be that that vaccine will arrive in front of people and they will not want to take it. They just won't turn up. And if there's not enough people who actually turn up to get the vaccine because they don't trust what the vaccine is, they don't trust the person that asks them to take the vaccine or the institution that is in charge of delivering it to them, then even herd immunity is going to stay far away. In the United States itself, I believe now about 60% of people are saying that they would be willing to take the vaccine, which seems to be a good thing, but it's not 100% of people, which to me is mind-blowing, given how much havoc this epidemic has already wreaked on the world so far. So that, I think, is the thing that we all should be worrying about now, and that I certainly, and I know many other people are worrying about these days.
Right. And considering this, considering the way you feel the role of trust operates in terms of mass immunization and the upcoming stages, what do you think are the implications that this has on designing a policy response to the pandemic? What are the factors that you would say that the government should be focusing more on in order to develop that kind of trust that would allow the whole vaccination process and the immunization process to go smoothly eventually?
That's a terrific question. And, firstly, I don't think that there's one solution for any particular area or particular country, because it really depends on all of these kinds of factors. But that aside, I think one example, of course, is just more information, right? Better information, clear information, and information delivered regularly in ways that work. And there's a lot of insights from behavioral economics and from various kinds of academic work around messaging that tells you what kinds of messages work. One of the biggest or kind of not biggest, but one of the sort of salient findings from a lot of work that I think might be relevant here is endorsements, right? So it's not the information itself, but who is delivering it and who is endorsing it that tends to matter. And that obviously is a fundamental trust issue as well. Do you trust the source of the information? If your local imam says that this is what you should be doing, are you more likely to follow that? Maybe if you're religious and you believe the imam. But if the imam is of a different sect, or you think that they're otherwise not a credible source of scientific information, maybe you won't take that, right? Maybe it's the government. Maybe you'll be more likely to take it into account if the political party that you have allegiance with, or the chief minister of your province, or whatever is sending you robocalls. That's entirely possible. So the biggest problem, the biggest worry, of course, is that there's so much information now. It's the exact opposite of the problems we had 20, 30 years ago in getting messages out to the public, which was that it was hard to reach everybody. Now the problem I see more is that it is so easy to reach everybody that any message, whether it is completely false or completely true, is likely to be treated the same way, and people will decide one way or the other based on what others around them are saying and thinking, and what WhatsApp group they're on, and so on. So information, I think the only real way that I can think of about cutting through this massive issue of information is trust, is to try and get the people that communities and individuals trust to deliver that information in ways that are credible and sensible and useful. And I know every time I make a phone call to any, I'll first get a message on COVID-19 just before the phone even starts to ring. And I think that that's fantastic, right? That's something that just keeps reminding me that there's a problem and I need to keep that in mind. But the next message about what to do, and the next message after that to make me get out of my house and go to a clinic and receive a vaccine, those also have to be provided to me in ways that I'm willing to accept them. One bit of research that I think is going to be fascinating by another CERP affiliate or a CERP team, which is by work on imams in Pakistan by Kate Waborny, Uzair Junaid, and Lala Rukhan. I think that's going to be, the findings from that study are going to be really exciting. I don't know if they've got findings yet, but I know what they're doing is about trying to first, or at least what they've done pre-vax. This is not about the vaccine specifically, but it is about adherence to restrictions on Friday prayer. And at the time when it was suggested that people not go to mosques because it was extremely dangerous to do that. They went out there and tried to understand the extent to which training imams and working with imams would actually improve people's adherence. And there's similar work that's been happening in these areas, in this particular area around the world. In Bangladesh, there's a study by Mushfiq Mubarak at Yale and his co-authors who've also been looking at a very similar set of questions around imams and religious leaders. And I remember back in the early days of COVID, when it was Ramzan, and there was a question of whether or not to go for Taraweehs. And I remember one imam at a mosque going viral on social media, who, by giving a 30-minute lecture on, are you crazy? Why do you want to, subject yourself and your family to a potential deadly disease? and even though it is permitted in the text, and it is permitted in the Sunnah, and it is permitted by all the religious leadership to skip the Tarawih in the mosque and to do it at home and all of that. Why are you then bringing this down? So these kinds of messages, I think, really move people when they come from unlikely sources that tell you, no, this is this is this is the way you should do things. And so I think going forward, vaccinations, etc., any other palliative measures, any other preventative measures, and particularly, vaccines or not, life is not going back to normal for at least a year, 2 years, because not everyone's going to be vaccinated, even if we could vaccinate them, or there's just not enough vaccines available. So for at least a year or 2 years, things are going to be slow. There are going to be lockdowns, there are going to be masks that need to be worn, there are going to be social gatherings that need to be avoided. And involving the people that are trusted in delivering these messages to try to cut through the noise of the information that everyone already has access to is, I think, going to be crucial in trying to contain and ultimately tackle this epidemic.